I am Dr. Radhamany, Professor and Department Head of Obstetrics and Gynaecology, wing of Amrita Institute of Medical Sciences, Kochi, which is a tertiary care center. We have an excellent fetal medicine department, which is with the higher versions of Vodus and E10, which is very essential to diagnose fetal intrauterine cardiology defects of the heart of the fetus. And we have an efficient fetal cardiology and the fetal medicine department, and also excellent neonatal care we are offering. And so that we are now, and also a pediatric surgery team we have, and so that we are now able to do fetal intrauterine interventions, which is available only, the only one center in Kerala is Amrita, wherein we are able to do intrauterine interventions. So that now we are able to deal the fetal anemia that is due to RH incompatibility. In previous years, usually intrauterine death occurs in these situations where fetal anemia is there. Now it is because the ultrasound we are able to detect the fetal anemia by the Doppler studies of the cerebral vessels, which is able to pick up the fetal anemia and the fetal hypoxia. Now, so that at the particular level we do intrauterine transfusion, so that we are now able to save the life of the fetus. We are able to save so many lives intrauterine. And also now our center is an excellence in intrauterine fetal cardiology interventions, and recently we had a intrauterine balloon angioplasty, which is a number one, which is the second in India and only one, first done in Hyderabad and the second time in India. This is because of the dedicated work of the fetal cardiology department that we are having, with the coordinated work of the fetal medicine specialist, perinatologist, and the fetal pediatric surgeon. Now we are able to save the intrauterine fetus having cardiac defects in our center. Previously this was not possible, and now because we have started all this, and then we have an efficient pediatric genetics department, so that this is offering counseling to the parents who had a congenital birth, who gave birth to fetus with congenital defects, and they came to us to know what is the success rate, what is the recurrence rate of this having any congenital defects further in the second pregnancy onwards. So we have a dedicated genetics and an efficient Dr. Sheila Nambudiri, who is famous worldwide, and she is able to detect all types of syndrome, and she is able to counsel the parents. So many are bringing their children to us to get evidences for that. And then so the pediatric surgery department is doing surgery like exit procedures, so that immediately after the head is born, we are able to do the surgical options of the swelling of the neck and all. And so ours is a center of excellence for fetal medicine. When I started my career from 1982 onwards, at that time actually for the RH incompatibility, which is very common, usually the fetus dies, severe anemia, intrauterine death of the fetus occurs, and on that days we depend upon the bilirubin content of the amniotic fluid, so that we take the amniocentesis and assess the bilirubin content. Now the things are changed in such a way that there is no need for taking the amniotic fluid. We are now able to detect the fetal anemia by the ultrasound Doppler study of the middle cerebral vessel of the vessel, wherein there is a cutoff value in which the fetal anemia we can detect, and then we can treat in the intrauterine period by giving blood transfusion to the fetus through the umbilical vein or the portal vein. And so now we are able to save the life of that child, and then we deliver at the appropriate time. These are all possible for the very recent years only. These are all possible. Another important thing is previously when there is an intrauterine cardiac defect is detected, like tetralogy of Fallot, or so many defects are there, and now it is possible to know what are all the defects that are able to survive. The fetal survival is possible. The immediate interventions, immediate neonatal care that we provide to the neonate at the time of delivery, so that neonatologist and the pediatric cardiologist all are there in the theatre to save the life of the fetus, and we immediately shift the patient to neonatology, and then to the cardiology team will hand over the neonates. Now in our center it is possible to do intrauterine cardiac surgery like fetal balloon angioplasty for the ductus aortic stenosis. We have done successfully, and that fetus I have done cesarean section for the baby 2-3 weeks back. Now the baby is doing well. Today the pediatric cardiologist met me and said me that no fetal interventions are required because we have done already the surgery in the intrauterine life. So all these things are possible for throughout all these 35 years. What was not possible in that year about 20 years back or 10 years back is now possible. Even though the maternal mortality when compared to other states of India, in Kerala it is less, still the postpartum hemorrhage, that is hemorrhage after delivery, is the number one killer even at Kerala also. So now we have through various associations we are giving awareness to all the medical and the paramedical staff about conducting the delivery, what are all the measures to be taken to control the hemorrhage, so that we have introduced active management in the third stage of labor, so thereby we can reduce the incidence of postpartum hemorrhage. And once the postpartum hemorrhage occurs, the multidisciplinary team should be alerted, and then the various therapies we give including the drugs and the tampering measures to control bleeding. And if the bleeding is not controlled by this, then a timely decision to conserve the uterus before the patient went for shock and hypoxia and hypovolemia and DIC. That is, we have to take steps to correct the bleeding by surgical options to ligate the vessels to control the bleeding, and also if all these measures fail, only we go for hysterectomy. So the right time decision is needed to take the to conserve the uterus and also to save the life of the mother. When there is ongoing bleeding, in spite of all the drugs to control the bleeding, and also the pressure packings and the tamponade that we offer to the patient to control the bleeding, in that setup we have to take decision to right decision. That is, I told you before the patient went for shock, that is a right time to take decision for surgery, that immediate surgery is needed. Even delay in more than 1 hour will not able to conserve the uterus. We may force to do a hysterectomy for the young woman.